Okay. Physiology of respiration. So, as I said, the physiology of respiration is different for a spontaneously breathing child, and physiology of a ventilator child is different. So, we should understand basic physiology so that the same physiology, there is something called applied physiology. So, whatever we have learned over here should be applying into the respiratory mechanics when we are applying. So, what is respiration? Very simple question, right? Taking in of the oxygen and removing of the CO2, right? So in this, respiration, whatever you said, is an external respiration where uptake of oxygen and the excretion of the CO2 from the lungs. There is something called internal respiration. The internal respiration is at the capillary basilar membrane, there will be exchange in the lungs at a point between the capillary and the lung alveolar capillary. There will be exchange of O2 and CO2. That is called internal respiration. What is called cellular respiration? A set of metabolic reactions where the oxygen will go inside the cell and inside the mitochondria to generate ATP. That is called internal cellular respiration. So we have got external, there is something called internal, there is something called cellular respiration. So what are the components of the respiratory system? If you see, there will be airways, right? There will be parenchyma. In the parenchyma, there will be vasculature. This is about the lung and the upper respiratory. And towards, apart from that, there is something called chest wall. Chest wall plays a major role in children, both for the spontaneous breathing, both for the ventilation. So it has a major role. So we should understand how this affects. So airways, we know there is something called upper respiratory tract. There's something called lower respiratory tract. What is upper respiratory tract? Till what point you call this the upper respiratory tract? You write URTI, you write LRTI. So what is called what is till what point you call it as upper respiratory tract of so trachea, bifurcation of trachea or starting of trachea? Epiglottis. So till to the starting of upper respiratory tract infection, upper respiratory tract nasal cavity until the end of the larynx. So the moment the trachea is open, trachea is started, the moment starting of the trachea, not to the bifurcation of the trachea. So from that point, it is called lower respiratory tract. So which includes trachea, bifurcation of the trachea, primary bronchi and lungs. This is the gross we are telling. How does it help you? So this is the point which helps you. There is something called trachea, which trachea will divide into bronchi and then bronchioles, then into the terminal bronchioles. How does this, what is this? This is the point beyond which there will be gas exchange. So from here to here, only the oxygen will go inside or the CO2 will be going inside. There will be no exchange of O2 and CO2. It's all the point to the bronchioles, there will be no gas exchange. This is called till the terminal bronchioles. It's called there is some word to it till to from that point to this point. We call it as the dead space. What dead space it is? It is called anatomical dead space. What is physiological dead space then? If it is anatomical, then what is physiological dead space? See, this is a structure of the lung till this point, which is anatomically not fit for a gas exchange. Anatomically not fit for gas exchange is called anatomical dead space. Because you'll heard basically this class you'll learn many of the terminologies which you need to understand so that it doesn't become foreign to you for the next sessions on ongoing. So from here, this is gas exchange happening, and physiologically for whatever the reasons, because of pneumonia, ARDS, whatever it is aspiration. Something has happened to that part of the lung which should be involved in gas exchange, is not able to involve in the gas exchange because of some pathological process that is not happening. This physiological dead space, right? So this or this place it can happen. That is physiological dead space. Your entire half part of the lung is gone because of ARDS or whatever it is. That part is not involved in the gas change, that is called physiological dead space. So someone will be using the gas exchange has been affected because of physiological dead space. You should understand it is a physiological way of explaining that the gas exchange is not happening in the particular part of the lung. Right? So now this is about the airways. Now we'll go into after the airways, you go into the lung parenchyma. Parenchyma, you got enormous number of alveoli, and there'll be the surface area is very huge, nearly 50 to 100 meters square. So the effective gas exchange will happen in the lung parenchyma or the alveoli. So how it is going to help you in understanding the later, I'll tell you. How is the parenchyma and interstitium? It's vasculature also, because you have two type of capillaries in the vasculature. You know what is pulmonary artery and pulmonary vein? What is pulmonary vein? Will it causes oxygenated blood or deoxygenated blood? Pulmonary vein. Pulmonary artery? Yeah. Okay. This is the basic understanding of that. There's something called a pulmonary vascular resistance. Pulmonary vein and pulmonary artery just taking out of what you call oxygenated and this. There is something called pulmonary vascular resistance. Resistant is very important for you understanding in the ventilation as well as in the spontaneous breathing. Someone is having a respiratory distress. The pulmonary vascular resistance, if it is increased, normally pulmonary vascular resistance is less or systemic vascular resistance is less. Resistance is less in pulmonary vasculature. That is the time you mostly see, even if you see the shunts where what you call VSD, ASD, the shunt is different. Systemic vascular area to pulmonary vascular area. Always the shunt starts from left to right rather than right to left. Reason being, your resistance in the pulmonary vasculature is less compared to the systemic vascular area. So how does it help you? This is a factor. How it is going to help you, we'll discuss. You should understand the pulmonary vascular resistance is less than the systemic vascular resistance. How it is going to help you in treating a child, that we'll discuss. So the muscles of respiration. There are certain amount of muscles which are involved in inspiration. There are certain amount of muscles that are in expiration. Before that, which part of the respiration is active and passive? Which is active, which is passive? Expiration. How? Can you explain that? It is a passive process. Hence, so it's very clear that there are certain muscles are involved in inspiration. Certain muscles are involved in expression. An expression can also be active when you want to do forcefully. See, inspiration needs your intercostal muscles and your diaphragm, and there will be some accessory muscle also. Normally, what muscles you need to do? Diaphragm, external intercostal muscles. These are the only two muscles which are involved in normal inspiration. Someone accessory muscle usage, if these muscles support or power is not sufficient enough for the inspiration, then these muscles also will come into the role. So if they are also being involved excessively, that is the time you see a lot of external what do you call accessory muscle usage. If someone using accessory muscle usage, then your actual muscles of diaphragm or accessory external intercostal muscles are not sufficient enough to give that inspiratory effort. Means the child is having some difficulty, definitely. Whatever might be the reason. That could be neurological, that can be muscle related, that can be lung parenchyma related. That is not the question. But you can say someone using external accessory muscles, that means that the child is having some problem. That is the point you should make it. For expression, normally expression does not require all the muscles. What you need is, I'll show you the diagram. The spontaneously breathing child, what do you need? The movement of how does the spontaneous breathing? The air outside the body comes inside the lungs, and the CO2 that is there in the lungs will go out. Right? How does it happen? Because there are something called external intercostal muscles. There is something called diaphragm. Show you the picture. This is the normal diaphragm that you see when someone is running normally. So when this diaphragm contracts, diaphragm, whatever it is, a dome shape, it will come down. So your anteroposterior surface area, anteroposterior diameter, the lung is increased, right? And the diaphragm also expands laterally. One is anteroposterior, then axial. both the surface areas will increase. So thereby the space inside the lungs are created. The thoracic cavity, the space inside the thoracic cavity is enlarged. By this, if there is a space is increased, then the pressure within the thoracic cavity will drop. Certain amount of volume is there. You have created negative pressure by creating extra volume. If the pressure drops, then the air moves from the higher pressure to lower pressure. Simple, right? Outside atmospheric pressure, say tomorrow thoracic cavity pressure becomes negative, less. So the air comes from the outside to inside. This is simple understand. So this space has been created, one by the diaphragm, the other is by the intercostal muscles, external intercostal muscles. So this space will allow the negative pressure so that the air comes from the outside to the inside. This is understanding. The same thing which I am showing in the reverse. There is something called pump handle movement and bucket handle movement. So with the contraction of this external intercostal muscles, the rib cage, whatever it is, it will move like this. Pump handle, it will move like this. It also creates anteroposterior diameter. It moves upwards because of one is because of the inside the lung because of the diaphragm. The other is because of the rib cage that is caused by external intercostal muscles. That contraction will allow the chest to move, chest wall to move. So your anteroposterior diameter is increased. This is how it is increased. Just to demonstration of the same thing was shown. It is very simple way of understanding. Now, if this part is clear, till this part is clear. This is very basic. Now let's go this everyone know. Now let's go a little bit into the pressures of the lungs. So there is something called, these are the concepts. There is something called intrapulmonary pressure. There is something called intrapleural pressure. So let's understand the simple things only. Will not complex things, but it is good to understand this dynamics. This is lung. This is pleura. This is chest wall. Clear? The pressure which in the lung is called intrapulmonary pressure. The pressure that is there in the pleura is called intrapleural pressure. Usually with the breathing, just see how the changes do happen in breathing. This dotted line is called intrapulmonary pressure. So during inspiration, it starts from 0, right? Intrapulmonary pressure during the this is spontaneous breathing, mind it. This is not a ventilator pressure. This is spontaneous breathing. So intrapulmonary pressure, as I said, when you're taking inspiration or when you're starting off because of muscle activity, your intrapulmonary pressures will drop, right? So this is how it is depicted here. In inspiration, your intrapulmonary pressures are dropping. It from 0, it comes to -5, and then by the end of the inspiration, it comes back to the 0 baseline status. Whereas intrapleural pressure, it becomes much negative during the inspiration. Say if you see that this is during the inspiration. Now during the expiration, this is -10 of this is intrapleural pressure. So by the end of the expiration, by the end of the inspiration, your pleural pressure becomes much negative. Negatives or negative. The pressures will be very low, and by the end of the expiration, your pressures will come back to the normal status. For as intrapulmonary pressures, during the expiration, it will increase and it will come to the baseline. So you should understand during the inspiration, your intrapulmonary pressures and your intrapleural pressures becomes much negative, and during the expiration, it becomes positive. Because it comes from the negative pressure to positive pressure, it becomes like what you call a passive process of movement of the air. This is only to understand. Okay. So how does it help in you understanding? How does why all you know this pressure is it required? So because this helps in understanding something called ventilator concepts. For you to understand the ventilator concept, this is mandatory. So the pressure which in this part, that is called intrapulmonary pressure. The pressures which in the pleura, that is called intrapleural pressure. The C is atmospheric pressure, right? These are the three pressures. Because when you read anytime about the ventilation or anything, there will be multiple pressure concepts that will be coming. If you don't understand this concept of transthoracic pressure, transpulmonary pressure, you'll not be able to understand anything. Right? 3. intrapulmonary, intrapleural, atmospheric. These three pressures are clear. Now, what is transpulmonary pressure? The pressure difference between intrapulmonary and intrapleural. The difference between the two, suppose this is 5 and this is -5. 5 minus -5, that is 10. Usually pleural pressure will be negative. That's why 5 minus 5. So from 5 to -5, the difference is 10. That is called transpulmonary pressure. So you should understand the difference of pressures between the lung alveoli and the pleura is called transpulmonary pressure. This has to be understood. Difference between pleura to the atmosphere. This is called transthoracic pressure. The difference between the lung alveoli and to the atmosphere. That is called transrespiratory pressure. But you should understand is the pressure which you will be able to you will to detect. These are the rest of the pressures you will not be able to detect. Pleural pressure which can be detected, lung pressures which can be detected by the ventilation. The difference between the both is called transpulmonary pressure. This is the pressure. This is the pressure gradient which will decide the amount of air to come inside and the amount of CO2 to go out. This pressure is very important. So only understand the concept. There is something called transpulmonary pressure, which decides the respiration. It's the only pressure you need to understand here, which decides the respiration that is coming out of CO2 and coming inside of the O2 is decided by this pulmonary pressure, transpulmonary pressure, which is the difference between intraalveolar and intrapleural. Only understand this, rest of things forget. Even if you forget rest of all the things, don't worry, but just forget. Just remember this thing. These are the pressures. So that is called spontaneous breathing. Now coming to the ventilation. So during the spontaneous breathing, there is something called your muscles which are acting against they are opening the things. Now for the ventilation, the machine will be giving the breath. During most of the times, your ventilation, if you take mechanical ventilator, there is no effort from the patient. There will be a force from the ventilator. There will be some pressure, volume or force given to the lung, so that the lungs do expand. On the right, ventilator will give some amount of force to expand your lung, to expand your chest wall. There is some work done by the ventilator to allow the lung to expand or the chest wall to expand. So how much amount of force or the work is there? What amount of work that has to be done with it? It's called work of breathing. The work required for the ventilation is from the elastic components of elasticity. Absolutely worried. Absolutely worried. I can understand. Is I took this for you to teach this topic. It's going to be difficult. So I will put this. I need to understand. No need to know. Just understand this concept so that it becomes easy to understand. So what is an elastic structure? Resistance that is shown by the ability of the structure not to get deformed. It's called elasticity. Suppose this wall, if I given force, is it changing its shape or volume or shape? No. So this is very highly elastic structure. Very highly elastic structure. Suppose I'm given to that pillow. Given that pillow, we can apply the force. When the force is applied, it will change. That is less elastic compared to the wall. And not say low elasticity. Take clay. You apply force. It will change its volume. That is called very low elastic structure. So your amount of force to be given for structures will be different for different elastic structures. This is called elasticity. what is called compliance that we'll talk about. There is something called compliance, there is something called elasticity. This you get in when you're reading about the ventilation. And there is something called resistance. So for the elastic property of the lung is when when you're given some pressure. So the physical structure of the property of the lung is not to get deformed. You should be given sufficient amount of force so that will change its shape and it will not deform completely so that it can come back when the force is released. You have to give such amount of force so that the structure of the lung, structure of whatever you are giving, it changes and it expands. That is called urine. Working against the elastic property of the lung, the chest wall. All right, you understand now? You are giving certain amount of force so that the structure, physical property of the structure, that is called elasticity, to overcome both for the lung as well as for the chest wall. Clear? So to overcome the elastic components of the lung and the chest wall. The other thing is the resistance component. What is resistance? So if you're trying to pass some force through open structure and to a very closed structure, resistance is something, the amount of pressure required to overcome what do you call a pressure gradient is required for movement of air from one place to other. That is affected by the resistance. So it has both the lung and chest wall has got some resistive capacity. The airway has got the lung. This resistance is also very important. The elastic property you understood, right? I'll not go into the details. To understand what is called elastic property, that's it. Not really details. So how does it affect it? Because of the structure. Because each structure has got its own elastic property. Suppose chest wall has got different elasticity. Lung itself has got a different lung elasticity. A normal lung has got a different elasticity, and a diseased lung has got different elasticity. Suppose a lung has got a fibrosis, so there will be a lot of collagen in the lung. So it becomes harder. So the amount of force to be given for that lung to expand will be higher, right? So elastic property will be decided on the normal lung or the diseased lung and the chest wall also. If your chest wall is, if you see the chest wall of the children, small child, infant, and if you see the chest wall of the adult, it will be completely different. The chest wall of these are very pliable. Easily, even with the small pressure, the lung will expand, the chest wall will expand. Whereas with adult, there are a lot of fibros, a lot of subcutaneous tissue, a lot of collagen inside. The amount of force required to expand that lung will be higher. There is something called liquid interface. The amount of liquid that is there in the interface also matters. So if you see what type of structure is the lung, this is a viscoelastic structure. This is what has to be developed. This is viscoelastic structure. See, how does a surfactant feel? So it creates an interface where, see, suppose you take the balloon, simple balloon. Normally normal balloon is completely flat. If you are inflated with some amount of air, right? So from that point of air inside, if you leave it, it will collapse completely. And it has got no surface tension. Suppose there is a surface tension, there is some surfactant which has created the surface tension. Even with the some air inside, it will not collapse completely. So how does it help you in understanding the lung ventilation? I'll show you. So there is something called surface tension, which is created in the surfactant, which is needed to prevent the lung collapse. What happens if the lung has collapsed? How does it help? Again, you're giving any of the air to collapse the air, to collapse the alveoli, or the open alveoli. Now you're going to give some amount of pressure or volume for it to expand. Collapse हो गया तो क्या होगा? But you are giving pressure now. Again, see, you have given some amount of pressure. Lung has expanded. Gas section has happened. Right. The moment pressure drops, lung is collapsed. Again, you have given pressure. Lung opens. Section happens. This is also happening, right? There is a gas section happening. Why is what is the problem in collapsing? Let it collapse.
The expression that will be because there is collapse.
What happens? What happens? Collapse हो गया तो क्या होगा? Anyway, you're opening, right? Second amount of this is spontaneous ventilation. I'm talking about ventilation. If you given pressure again, the lung will expand, and the exhalation will happen. Yeah, again, the second breath, within 0.1 second only, or within 1 second only, you're going to give another breath, right? It allows the lung to open.
It's like this and like this. It is like this and like
This is like this. You've given pressure, open. This is one thing. It's completely collapsed. You've given pressure, open, and completely collapsed. What is the problem in this? During this phase, the CO2 and oxygen will do happen. CO2 and oxygen do happen. It happens. Ventilation and oxygen do happen. What is ventilation? Ventilation is removal of CO2. Oxygenation is dispensing of oxygen into the blood. There are many reasons. I'll show you. That is the reason. It's not about only. To show you the hysteresis loop, where you are able to understand. What is compliance? So elasticity you understood, right? Right. Now what is compliance? Wall is more compliant. What is compliance then? Okay. So the change in volume to the amount of pressure that you have applied, that is called compliance. It is opposite to the elasticity, which is opposite to the elasticity. Is it exactly opposite to? So change in the volume to the change in the pressure. So if you have given certain amount of pressure that has caused a change in the volume to that lung or to the any structure, that is called compliance. If the change in the volume is high, that is called highly compliant. If the change in the volume is less, that is called low compliance. This wall is least compliant, highly elastic and least compliant. You can also understand in a very gross way, elasticity and compliance are quite opposite things. A property of any structure, it is quite opposite. Now, how does it help in your understanding of lung mechanics? Is if your lung is less compliant, if your lung is less compliant, the change in the volume or change in the pressure will be less. If a lung is highly compliant, the change in the volume to the change in the pressure will be high. Understood? So having a good compliance, high compliance is good for the, in the gross way to understand. If someone says the lung is good compliance, has got good compliance or high compliance, that means the lung is good. Because the small changes in the pressures also, there will be change in good volume. So the amount of pressure required to change to produce certain amount of volume will be less for a lung which has got high compliance. Someone's lungs compliance is good or high, the amount of pressure required to change volume. Suppose you want a tidal volume of 100 ml. Suppose if the lung compliance is high with the pressures of only 12 inspirator varieties, you are able to generate that tidal volume of 100. So for a change of pressure from 0 to 10, you are giving a tidal volume of 100. Is for 100 volume, 100 by 10 is equal to 100. For 100, you need 10. Suppose the lung compliance is poor or low, right? So with the change of pressure of 10, the change in the tidal volume is only 50. That is what poor compliance. Clear? So compliance is very important. The reason why we take, most of the times I ask you in the ventilator also, last previously also, to write compliance dynamic karke you have got on the ventilator. When I'm doing something called peak titration, I write there something called compliance. So if you have a good compliance, the pressures are good. So how does this compliance is going to help you? How does it help you in ventilation? That is a different concept. I'll show you. So the important thing that you need to understand is change in volume by change in pressure is called compliance. A good compliance, a high compliance is good. A bad, low compliance or is bad for ventilation or bad for the lung. It's not so समझना है. And the second most important concept, second, elasticity and compliance are quite opposite events. You would understood now what is a compliance. So compliance you understood. You understood what is called elasticity. Now we will talk about the resistance also. What is, how does it help you in understanding? So you know how to compliance when you are talking about a ventilation. When you are dealing with any child on ventilator, you should understand how does compliance will help you. Suppose compliance is set up with PWP of 6, you got compliance of 4. With the PWP of 7, you got compliance of probably 3. Which peak is good? With the PWP of 5, you got a compliance of 4. With PWP of 6, your compliance is 3. Which PWP is good? Whichever has got a higher compliance, that is good, right? That is what you should understand. So if compliance is high, then the amount of pressures that you are giving at that particular event is good. So you should ventilate at that pressures. So I'll show you PWP to understand it in a better.
Last slide. You said that elasticity and compliance is opposite.
Absolutely.
The elastic structure is compliance.
Elasticity is different from elastic. Elasticity is a property. Elastic is a, you give, suppose the moment you give force and is completely changed its shape, that is called elastic. That's called elastic. You've given some gum, you've taken this, that is called elastic. Rubber band is very elastic. Elasticity is different. Elasticity is a physical property of the structure. Highly elasticity, if some structure is having very high elasticity, that means the ability of the structure to change its shape is very less. Elastic is different from elasticity. And that's why really elasticity and compliance are quite opposite things. So this you got understood, right? So elastic structure has high compliance and rigid structure has low compliance. So compliance is dependent on initial lung volume. So if someone is having lung volume, some basic lung volume, if someone is not having very less, someone is having certain amount of lung volume, someone is having no lung volume, the compliance will be different. Like the way you understand a balloon which has got some volume inside, to further inflate it becomes easy. Some balloon which has completely flattened, to inflate it, initially you require higher force, right? So if someone is having certain amount of volume in the balloon, then it becomes higher compliant. If the volume is completely low, it becomes little less compliant. Just understand only the balloon concept, you will be able to understand. So this is the point. Initial lung volume from which is measured, a large lung volume compliance is good. If it is very, the large lung volume is already balloon is very inflated higher, then it becomes very less. Compliance becomes less because there is no further elevation of the lung to expand. It depends on the property of the lung. Okay, so now let's put this PV loop. This is one loop which I see commonly in the ventilator. PV loop is, this is pressure, this is volume, right? With the change in the pressure, there will be change in the volume. This is simple. On x-axis, you have got a pressure. On y-axis, you have got a volume. The pressure is increasing, the volume is increasing. Here, but there is a lot of information in this one single loop. A lot of information and concepts involved. See, from 0 to 4, even 5, I guess. The change in the volume is not even 5. From 4 to 8, again, From 0 to 8, suppose if you take from 4 to 8 and 0 to 4. From 0 to 4, the change in the volume is very minimal, right? From 4 to 8, the change is again 4 by change of 4. The volume change from here to here is a bit higher compared to this. Units, this is 5. From 4 to 8, it is 20, suppose, to understand it. So for 0 to 4, the change in volume is 5. From 4 to 8, the change in volume from 5 from till to the 20, it is 15. Understood? Not understood. 0 से 4 आने के लिए आपको change in volume is 5. 0 से 8 तक आने के लिए your change in volume is 20. Right? So for 0 to 4, the change is only 5. From 4 to 8 is nearly from 5 to 20, it is 15. Yeah, 0 to 4 तो एक ही टाइम होगा सर. Pressures are from 0 to 4, only 4. Difference is 4. Change in volume is 5. From 4 to 8, the change in volume is 15. Right? The same concept. The balloon, which is completely flat over here, for the force, for 4 force, the change in volume is only 5. It has got certain amount of volume. That is the reason from 4 to 8, it has inflated a bit more. Right? From 8 to 12, if you see 8 to 12, you say the dissection is got 200. Right? Here from the 8 to 12, the major difference of volume is very high. Higher, right? Not so very higher. From 12 to 20, if you see, 12 to 16, if you see, 12 to 20, you see. From here to here, even with the small changes in the pressure, the volume is increasing exponentially. From 12 to 20, if you see, the change in the pressure is very high. From here, if you see from 20 to 24 to this point, from 24 to further, the change in volume from here, from 24 to further, the change in the volumes are very less. They said initially, same the balloon concept. Flat, the pressure required to change the volume is high. Certain amount is inflated, so your pressures are a little high. No, your volume is got inflated with smaller volume, small pressure. Further, if you increase the pressure, the volume is expanding further. This is an inspiratory thing. This is an expiratory thing. So thereby you should understand if you have a certain amount of volume in the alveoli, same concept, the question which I have asked you. If certain amount of volume is there in the alveoli, not completely collapsed, even with the smaller pressures, you can expand the lung. Otherwise, you'll be giving very, very high pressure. So to expand that lung. This is one explanation why the lung should not be collapsed. One single explanation, but there are other reasons also why the lung should not. There is inflammatory, there are something called inflammatory causes, there is something called lung injury. There are many other concepts why you should not allow the lung to collapse. Bar collapse or that collagen will be broken and the lung will be further worsened. The other thing, there will be inflammatory response and there will be a lot of inflammatory mediators coming out of this and will further worsen. There is other explanations, but why as such for the, if you see only the force and pressure concept, if the lung is little bit opened, it becomes easier with a small force also to open the lung. So how does it help you in ventilation? This is a concept, right? How does it help you in ventilating it? So there is something called lower inflection point. So your PWP, positive end expiratory pressure, that means the pressure that is there throughout the ventilation to keep the alveoli open should be at your lower inflection point. So if you keep your PWP at lower inflection point, that the lung alveoli will be open. So that becomes easy for us with a small force only, the small pressure only, we'll be able to get good tidal volumes. Otherwise, inadvertently, if you keep your PWP less at around 4, what happens? The amount of force given to the lung to expand will be higher. So thereby you are injuring the lung. So this concept will help you understand what is the PWP or what is the force, what is the PWP that should be kept during the ventilation so that lung becomes easily compliant and and easily opening, easily expand. So this is called the lower inflection point. There is something called upper inflection point. So a point beyond which, even if you change the pressure, the change in the volume is less. So if you're giving beyond this, you're giving higher force, but the change in the volume is very less. And in fact, if you're giving higher pressures, it will injure the lung. So your PWP should be at upper inflection, lower inflection point, and the P peak or P platy or whatever it is. So those should be not crossing your upper inflection point, right? So this is the concept that you have to understand looking at the PV loop. So one more important aspect is, so coming to the compliance, if you apply the compliance over here, if I say the compliance is good from this point, the compliance is good from this point, here the compliance. So your compliance of the structure of the lung will differ with the different pressures and different volumes. Here, the compliance of the lung is good. From here, the compliance of the lung is good. Till this point, upper inflection point. Beyond this, again, your compliance, because change in the volume or change in the pressure from this point is less. Here is also less. So your compliance will be higher between these 2 points, and hence your ventilation should happen between upper inflection point to lower inflection point. This is called zone of safe ventilation. Giving pressures is not the concept. Giving a right pressure so that the lung volumes are adjusted such a way that the pneumonia, whatever the disease process are ongoing, will have, if you give lot of pressures, it will damage the lung. So you have to select the amount of pressures, select the amount of volumes and dynamics so that you do a zone of safe ventilation. This is how you decide. So suppose you see PV loop, I've started on ventilation. I start PV loop. I see my lower inflection point. I see my higher inflection point. So if there is a appearance of this beak, bird beak appearance, that means I'm giving higher P inspiratory pressures, high P peaks. So I need to come down, right? And if it is here over here, if my this is very narrow and it is coming to the x-axis only, probably I'm giving lower PWP. This is one way of deciding PWP based on PV loop. But there are other ways also to decide how much PWP we should give. Right? So same, so there is something called hysteresis. You know what is hysteresis? Okay. So simple concept. So at pressure of 12, the volume is how much? 100. This is inspiratory phase, right? With pressure of 12, the volume is 100. You see the expression at 12, the pressure is at a pressure of 12, the volume is here. You see the volume. How much? More than 300. Why? So the change in the volume when compared to inspiration to the expiration is called that concept is called hysteresis. When the alveoli are opened well and the compliance recruitment happened well, the change in the pressures, even when the recruitment has happened, the lung has volume opened up very well, so that the pressure, even the pressure is falling also, the lung has the capacity to retain the volume. It is called hysteresis. No, doesn't matter even if you don't understand, but you should understand if the lung has expanded well, recruited well, even with the small pressures also, the changes in volume will be higher. That is what you have to understand. Now coming to the resistance. So you understood what is called elasticity, compliance, PV loop, how to decide on this. Now we come to the resistance. What is called resistance? So resistance is, one is pulmonary resistance, the other is chest wall resistance. Right. So pulmonary resistance because of the airway, which I showed you. Lung resistance is because of the lung parenchyma. So the resistance is ratio between the pressure gradient required to move the gas from air to alveoli onto the air. So you have to create a certain pressure gradient so that air moves from one place to another. So why you need to understand the resistance is because I'll tell you. Scenarios, there will be a lot of scenarios. The resistance plays a major role. Which part is giving more resistance? Which part of the respiratory tract is giving more resistance? So that you need to address it. Otherwise, you'll be giving the air, but it will not go into the lungs. The amount of pressure required to overcome the resistance will be higher if you don't address the resistance. Suppose if you have given a 4 years child, a 6 years child, you ventilated with a 3 size tube, a 3.5 size tube. The radius of the tube is very, very low, right? So the air to go inside, the force will be very, very high to overcome the major resistance that is given by the smaller tube. The same concept applies for the bronchospasm. The radius of the trachea or the bronchi as narrow, the resistance will be very, very, very high. So to overcome that resistance, the amount of force that has to be done by either by the ventilator or by the child by himself will be higher. So you need to address the resistance. If you don't address that resistance, then the amount of force required by the ventilator or per se by the child will be very high to have a ventilation. Right? So that is the reason you should address the resistance. So for you to address the resistance, you should know what are the concepts that are affecting the resistance. Right? So resistance can be in a simple way, which I told only by the radius, but there are many other factors that will decide the resistance. So the rates depends on the breathing rates, depends on the laminar flow. What is the type of the flow that you are giving, and radius of the airways, and what you call the velocities of the airflows. Let's go a little deep. Laminar flow is a straight flow. Turbulent flow is like mixed massage. Transitional flow is the phase where the bifurcation or where the what we call the laminar flow will convert into the turbulent flow. How does it help? Could you tell me where will be the resistance will be higher, or the upper respiratory tract or the alveoli? High or low? So that's a just a misnomer. But in the alveoli, the resistance will be least. Surface area is very high. The laminar flow will be the flow will be laminar. The resistance will be less in the alveoli, higher in the upper respiratory tract. In children, the resistance of the upper airways is very, very high. That is the reason, even with the small narrowing, even with the small situations also, they have a lot of distress. Whereas adults, even with this, they don't have respiratory distress. The resistance is contributed maximally by the upper respiratory tract in children. And we all know it is increased by stimulated by the parasympathetic. If you have a parasympathetic system or if you have irritants, cold or vasoactive medications will increase your resistance of the area. It is inhibited by sympathetic drugs. So implication is you will avoid irritants or the bronchoconstrictions. The thing you have to understand. Types of airway resistance, C. The same thing. This is a nasal cavity to the upper airway. And slowly it falls. So the terminal bronchioles, it falls further. Just understand the concept. Okay. What everything I told you. This way. There is something called time constant, which I'll tell you about basics of ventilation. I'll explain you what is called time constant. If in order to understand what is time constant, the time that is required for the alveoli to exhale the CO2, exhale the what do you call air, is called time constant. So this will help you in understanding inspiratory time and expiratory time. The amount of time required to completely evacuate the alveoli is that time constants. So for 4 to 5 constants, the amount of 95% of the air that is there in the alveoli will be exhaled, will be removed. Here there is a volume. 1 time constant, nearly 63% is evacuated. 2 time constants, somewhere around 80. 3, 4, 5. From the point of expression, from the point. This will understand how much expiratory time you should give for this child. So how you will understand how much expiratory time you should give so that the alveoli or the CO2 gets washed out. This is the concept of whether you will be able to apply it or not, that is a different story. Regional differences in the ventilation. So differences in the ventilation, this is a huge concept. Per se, this itself will take another 30 minutes to understand, but I will keep it very simple for you. There is something called a zone of different zones of lung. Upper zone, middle zone, lower zone. So if you see the pressure differences, you see the upper air zone, the pressure will be low because of the gravitation. Then if you see the lower part of the lung, the pressure will be high. So because of your gravitational force. That is because of pressures and ventilation. Ventilation will be very high. Pulmonary circulation, again based on the gravity, the pulmonary circulation, the blood flow to the upper zone will be less compared to the lower. So that is why there will be difference in ventilation, difference in perfusion, difference in ventilation perfusion in the different zones of the lung. That is the only concept you have to understand. How it is going to affect, that is, as I said, it is again a very lengthy topic to understand. But it's not so different parts of the lung have different ventilations and different perfusions. Simple. The reason you tend to, how does it help clinically is something, why you prone, why you have done proning for a previous slide, because you're trying to eliminate the gravitational force so that the ventilation perfusion are being universally distributed, or you allow majority of the lung to go into that ventilation perfusion. That is the reason you have altered the supine position to a prone position. You have better ventilation and perfusion. So one concept is different lungs has got different lungs, different ventilation and different perfusion. So the concept of supine position comes from this concept where you prone the child so that you allow you have maximum lung units being having good ventilation perfusion. Right? That is the reason we did proning. We will discuss the proning again. So there is something called pulmonary vascular resistance. As I said, systemic vascular resistance is higher than the pulmonary vascular resistance. So if how does the pulmonary vascular resistance will help? So if pulmonary vascular resistance is very high, then the gas exchange happening will be affected. At lung unit, if the pulmonary vascular resistance is high, the exchange of O2 from the lung alveoli to the pulmonary vasculature will be affected. If the pulmonary vasculature is very high, suppose the tube is, to make you simply understand, the tube is this much. Suppose O2 is coming inside, CO2 is going out. If the tube has become very much narrowed because of resistance, the O2 coming inside, CO2 coming outside will be affected. So your pulmonary vascular resistance is going to affect your gas exchange. This is the concept that you have to understand. So you have to understand, for whatever the means it is, you have to reduce your pulmonary vascular resistance if it is very high. By what methods? Because you should understand what are the different etiologies for having high pulmonary vascular resistance. There is some mechanism by where you can't do much. There will be certain mechanisms. Suppose your acidosis is very high, your pulmonary vascular resistance is going to affect. If your lung is completely expanded too much, your pulmonary vascular resistance is going to be high. If your lung volume is very small, okay, the lung is collapsed, then your pulmonary vascular resistance is going to be high. So there are certain concepts for which your pulmonary vascular. So higher pulmonary vascular resistance is going to affect your gas exchange, where your CO2s will be high, your O2s will be low. Number one. So there are concepts why the pulmonary vascular resistance is high. One is irritants, too much number of irritants. If there is an acidosis, higher acidosis, your pulmonary vascular resistance is going to be high. So correct your acidosis for whatever it is happening. Correct the acidosis. If lung volume is too much inflated, or too much collapsed, then that is also going to affect your pulmonary vascular. It is going to increase. So ventilated functional residual capacity. This concept, ventilated FRC, is something which you'll hear when you're attending any ventilatory sessions or anything. So ventilated FRC is the concept. Reason being, your pulmonary vascular resistance is least at functional residual capacity. First dictum line is pulmonary vascular resistance is least at functional residual capacity. What is functional residual capacity? If after the amount of the lung volume that is there after expiration is called FRC. See, I'll tell you multiple concepts, but at the end, I'll tell you some dictum lines. As I said for elasticity, as I said for compliance, as I said for resistance. So I'll tell some, you understand or not, this dictum lines has to be mug up or whatever it is, that has to be understood. Pulmonary vascular resistance is least at FRC. This is the dictum line. What is FRC? The amount of lung volume that is there after expiration, normal expiration, that is called FRC. So if you can ventilate your lung at that FRC, at that volume, then your pulmonary vascular resistance will be less. Your compliance will be good. Your resistance will be less. So you will be ventilating at FRC. How to know FRC is a different question. This is a concept where you have to ventilate FRC. There are ventilatory methods by which you will decide what is the FRC of this particular lung. In ventilator, you can decide so that you can ventilate at that point of the lung. Right? So if you want to know why pulmonary vascular resistance is high at higher lung volumes or lower volumes, there is something called intra-alveolar capillaries. There is something called extra-alveolar capillaries. So this capillaries, intra-alveolar capillaries, if it is lung is collapsed, the intra-alveolar capillaries also will be collapsed. So your PVR, pulmonary vascular resistance, will be high. If there is if lung is expanded too much, where the intracapillaries are overstretched and the extra-alveolar capillaries are also collapsed because of this pressure. So again, the pulmonary vascular resistance will be high. For you to understand, but simple concept to understand, your pulmonary vascular resistance will be high if the lung is collapsed or lung is too much expanded. Simple. You know what is shunt? What is shunt? Because these are the terminologies that you'll get when you're reading or any point of time, you will get these words. You should understand the concepts. You read again, you'll be able to understand. What is shunt? See, there is a lung, there is a blood. The blood will go and the O2 will come inside, CO2 will go out. This is normal. The blood is coming, but is not involved in the exchange. Because of lung alveolar pathology or vascular pathology, the amount of blood is not involved in the, or the amount of the lung is not involved in the gas exchange. One is dead space. The amount of space that is not involved in the gas exchange is called physiological dead space. The amount of this blood capillaries, the blood that is not involved in the gas exchange because of lung pathology is called shunt. Simply to understand, a deoxygenated blood comes to the lung, but it is not involved in the oxygenation process. It goes back to the heart and comes back to systemic circulation. That amount that is called a shunt. It can be because of lung pathology or vascular pathology. There can be anatomical shunts. Anatomical shunts is if someone's VSTs, where from the right to left shunt is happening because of increased pulmonary vascular resistance, where the pulmonary vascular resistance is very high and systemic vascular resistance is less than the pulmonary vascular resistance. At the VST point, lung, the movement is from the right to left. This is also an anatomical shunt, where the amount of blood, the blood that has to go to the lungs for oxygenation is not going. These are anatomical shunts. Physiological shunts is because of lung pathology, the blood is not involved in the gas exchange. It's called shunt. So there are two ways. One is anatomical, then is physiological. You should understand what is shunt first. The blood that is not involved in the gas exchange is called shunt. So it can be physiological because of physiological in the sense because of the lung pathology. Anatomical shunts is because of VSTs or anything. It's not so much. Dead space ventilation, I've told you. So These are the concepts of all the lungs that they'll get through. So someone's lung is affected. Where are the different ways of getting affected? It can affect the upper airway. It can affect the lower airway, including the alveoli, interstitium, or the vasculature. It can affect the muscles, or it can affect the central cause. These are the various ways of affecting the pulmonary pathology. Upper airway, if the airway resistance is high, it is going to affect. Lower airway alveoli is because of your compliance is getting decreased because of the lung pathology, because of pneumonia and all this. So that is because of that. Diffusion abnormality is at the alveolar and capillary. This is getting affected because of ARDS. ARDS is a concept where it is going to affect the diffusion abnormality. All right, that we'll discuss what is ARDS and we'll discuss later. So diffusion abnormality will also is at the level of alveoli and as vasculature, right? Neuromuscular weakness because of GB syndrome or anything, where the muscles involved in the respiration is going to get affected, and disorder of controlled breathing because of neurological reasons. It is also going to be. So these are the various physiological causes of increased lung compliance, increased chest wall compliance, decreased lung compliance. Suppose increased lung compliance is not a, that is the scenario that you'll face. You'll face is decreased lung compliance because of your loss of surfactant in the ARDS, or your lung fibrosis or pulmonary edema due to heart conditions, or that's it because of pulmonary pathology also. Your FRC is lost because of pneumonia, atelectasis, or someone's lobe has removed. These are the things where you will find the lung compliance is low. Decrease lung, this is only lung. Whereas for the chest wall, if your structural abnormalities are there in the chest wall or the spine, that is also going to affect your compliance of the chest wall as such. I just took this course only to make you familiarize the physiological concepts that are involved, so that for the next sessions you'll be able to understand. This is about only the physiology of breathing. So you understand how does a spontaneous breathing happen? How does our work of breathing by the ventilator you understood? Physical properties and physical properties of the lung and chest wall you understood. So the only concept that may not be help you in ventilating a child, but it helps you in how to ventilate a child. So only to understand. Actually, I thought of one more session also, but I think it's already taken good time. I think we should stop. What do you say? Much. I'll not teach you this. That is something applied respiratory physiology. Oxygen dissociation curve, you know, right? What is oxygen dissociation curve? What is ODC? You say shift to left, you say shift to right. What is it? One is that oxygen will bind to hemoglobin. It will the attachment and detachment from the hemoglobin will decide on the certain other factors also. There is something called shift to left. There is something called shift to right. So release of oxygen from the hemoglobin because of the factors. If there is an acidosis, if your temperature is very high, the oxygen is more needed for the patient, so there will be shift to right. Normal concept. If there is an acidosis because of low pH, and there will be shift to right. The oxygen will be easily dissociated from easily detached from the hemoglobin. So what is how do you assess? This is all gas exchange. Whatever we have spoken is gas exchange. Physiology of respiration and gas exchange. How do you monitor that gas exchange is happening well? How do you know that this is the underlying physiology that is you are thinking that is happening? but you should see something outside so that the physiology is happening in well. That is how we are going to assess by looking at PaO2, SaO2, PaO2 by this alveolar and atmospheric oxygen gradient. So all this gradient, PF ratios, how oxygenation index. This is all like you will be able to see. That is how you monitor whether the ventilation is happening or not well. So you've read about physiology and gas exchange. Now we'll discuss about how ventilation and the physiology is happening in the right way or not in the next class by looking at an ABG and X-ray. So we'll talk about how do you interpret based. We'll understand only few concepts of ABG. We will not go into the much further extreme concepts of ABG, which is not going to help you in any clinical way. Our ABG and just X-ray discussion over the next session would be in such a way which helps you to understand. आपको ABG देख लिया, you saw the ABG, you should be able to interpret the ABG and able to understand the physiology behind for this ABG, so that you need to do anything or not. That is the only concept that we need from the ABG. We don't need to go into the details of max details. We'll keep very simple. Even X-ray also we will keep very simple. How to read an X-ray, how to interpret your X-ray. We're not going into the details, hardcore details. We will not. Your session, huh? You make your own way. Anything is okay. Now I've got my PPTs to show you and explain you, but it is good from your point to read and make a short PPT, not make lengthy PPT. Keep it very simple. Understand yourself first of all, and then try to explain the rest of the PPT. You guys also read and come for the ABG and X. Okay. I wanted to show something there. See, you saw a primary assessment pentagon, right? So in the primary assessment pentagon, so there is something called respiratory rate, there is something called respiratory effort, chest wall expansion, and lung and airway sounds. These are the four things that you see in the breathing. Airway, breathing, circulation, disability, and exposure, right? Airway, you'll see whether it is patent or not. Right? Secretions are there, maintainable, not maintainable. In a breathing, you'll see the respiratory rate, effort, chest wall expansion, lung. Why do you see that? Just wanted to show. So respiratory rate. So if there are efforts are increasing, with increased rate, that is called respiratory distress. Your rate is increased, your efforts are increased, then it is called respiratory distress. Tachypnea is the first sign. Bradypnea, someone is having bradypnea, that is something it's definitely ongoing wrong. You need to do something immediately. This is based on the rate. Any age, if your rate is more than 60, less than 10 is abnormal. This is the regarding the rate you should understand. Right? Age specific rates are there. If rate is higher, that means someone is having distress. If someone is having respiratory rate being high, and if you have increased efforts for breathing, that is accessory muscle usage, then you need to call it respiratory distress. There can be a reason without respiratory distress, you can have a lot of tachypnea, right? Neurogenic breathing, or someone comes with a high acidosis secondary to diabetic ketoacidosis or someone. Your rate will be higher, but the child is not in distress. Efforts, second, apart from the respiratory rate, the other thing is respiratory efforts. If someone is having nasal clearing, if someone is having retractions, and again, you got different type of retractions, intercostal retractions, subcostal retractions, substernal retractions, all this. If someone is having retractions, or someone is having head bobbing or seesaw breathing, these are the based on the respiratory efforts, you're gonna say someone is having respiratory distress. So you will see the chest wall expansion in every movement, whether it is happening symmetrically or not. The second thing, you will auscultate and see the air entry is being equal or not. If someone is having these type of sounds, stride or grunting, wheeze or crackles, this is definitely unabnormal. These are the signs we have to do. మన దగ్గరగా ఐసీకా
Hello.
Any questions?